Well, good afternoon, everyone. My name is Ingrid Hendricks. I'm a librarian at the University of New Mexico Health Sciences Library and Informatics Center. I'm going to apologize for my voice. Not only do I have allergies, but I also have a little bit of a vocal tremor. So I'm not nervous about presenting. I've been doing this for many years, but it might make my voice sound a little bit quavery. So going ahead and getting started, what we're going to do today is we're going to do a very brief overview about the state of healthcare for people with disabilities. Going to talk about solutions to helping people who are caring for this population. And then a few tips about interacting with people with disabilities. At the very end, I have a number of resources which you can look at in your voluminous free time. So I've been a librarian for about 35 years. I've worked at about 4 different institutions. This presentation is based on a class that I've taught and that has evolved over time. It started with some physical and attitudinal challenges that I experienced as a person with disability who has a mobility disability when I was hospitalized a few times. And in speaking with med students and residents, I discovered that they said they didn't get any instruction in working with people with disabilities. So I had done some research into this, being a good health sciences librarian, and found that at the time there were very few medical schools that had any kind of training about interacting with patients with disabilities. So with a colleague of mine, we attempted to create a case for the problem-based learning sessions for medical students and shopped it around. And we kept getting passed to different groups and finally decided, well, this isn't working very well. So we offered a 6-week elective for medical students that went into a lot of detail about different types of disabilities, how to help people, things that they needed to know as medical students. But unfortunately, they did away with electives and they asked us to present this 6-week elective in 2.5 hours. So that, needless to say, got pretty cut. And I was still offering it through School of Medicine, but post-pandemic, they completely changed their curriculum. So that dropped out again. I'm looking to hopefully get that back in there. But I do present in the nursing program, the PT and OT programs, and have been asked to speak at regional conferences. And this is going to be my first time taking that 2.5 hours of content and squishing it into 30 minutes. So let's see how I do with timing here. I wanted to start with defining disability because it means different things to different people. But the Americans with Disabilities Act, which is our major civil rights act for people with disabilities, defines it in their number of ways that they define it, but specifically as a person who has physical or mental impairment that substantially limits one or more major life activities. Now, different organizations or different departments within the US government define disabilities differently, like Social Security and various and sundry other groups. But this is sort of like the major overarching definition. I personally prefer the World Health Organization's definition, which talks about the interaction of individuals with their health condition, but also includes personal and environmental factors such as attitudes, transportation, public buildings, and social support. So it's kind of a more encompassing global look at what disability is. And disability is very common It's will affect most of us at some point in our lives if we live long enough. So it's really a universal concept. Now, I wanted to also bring up the topic of ableism. I had asked the students if they knew what this was. They could define it for me. Some of them were like, ableism, is that something religious like Cain and Abel? I was like, no, it's actually an ism like sexism or racism, where you're looking at discrimination or prejudice against people with disabilities in favor of those who are non-disabled. So making assumptions about what you think a disabled person can or can't do, the assumption that people with disabilities need to be fixed somehow, and be more quote unquote normal, that disability is a tragedy and it's so sad that people have disabilities, are more in terms of our systems, architectural inaccessibility, and restrictions on Social Security disability rules that penalize people who work or get married. Now, there are a number of different models for disability, but these are kind of the two big ones. One is that the medical model, which some of you may be familiar with, which looks at disabilities. It's the problem, the issue has to do with the individual. So there's something wrong with you that needs to be fixed, and that's where the medical community comes in to try to adapt you personally so that you can walk, you can hear, you can speak, etc. Whereas the social model says, well, I'm disabled because the world is inaccessible, not because I, as an individual, have a disability, but my environment makes me disabled by not allowing me into buildings, not providing programming, interpreters, etc. As you can guess, the social model is the model that's embraced more by people with disabilities than the medical model. I also want to make the distinction between illness and disability. A lot of people think they're synonymous, but illness is really something that you have symptoms, you're dealing with a problem, you want this to be fixed or alleviated, and it's a problem to you, and you look to the healthcare provider as the expert, and your goal is to feel better, etc. Now, disability is something that is part of the patient, that's familiar to them, it's part of their identity. It may be stable or have features that are stable. And the individual, the person with the disability, is considered the expert. I know best how to transfer me, how to get into buildings, how to work, etc. And my goal is to live well with my disability. So it may have nothing to do with why I've gone to see a healthcare professional. So if you want to drop in the chat what you think the answer to this question is, we'll do a little interaction here. And I've got this picture of jelly beans. You all may remember those quizzes where it was like how many jelly beans are in a container, and you had to guess that. So if people want to just type in a number, what they think of as how many people in the United States report having a disability. Okay, so we've got 1 in 10, 1 in 4, 3, 1 in 10. Great, thank you. Well, let's see. It looks like Cat wins the jelly beans because it is 1 in 4 people in the United States report having a disability. I honestly think this is based, of course, like most government statistics, a little bit late. So more currently, especially with the COVID pandemic and long COVID, I think that number is actually probably more like 3. And also, I think this doesn't completely cover mental disabilities, which is something I should have mentioned at the beginning. This is going to be focused more on physical and sensory disabilities, because that is the type of disabilities I have more experience with. So just to give you kind of an overview of the types of disabilities, mobility disabilities are the most frequent ones. This has to do with adults, not children, but you see people, especially older people, using walkers and wheelchairs, etc. And as you can see by the little infographic there, more people over age 65 have a disability, which makes sense. Women, 1 in 4 have a disability, and of minority groups, American Indians and Alaskan Natives are the group that have the most experiences with disabilities. In terms of sort of social determinants of health, people with disabilities fare much worse. There are almost double the number of people with disabilities are unemployed. So people with disabilities are in the dark blue bar, can be the victim of violent crimes, have cardiovascular disease, obesity, smoke, and don't engage in any kind of leisure time physical activity, of course, because it's difficult to find a gym that's accessible, or to just even find accessible equipment that you can afford, or just activities that you can do as a person with a disability, depending on your disability. Also less likely to be current with mammograms, or not receiving needed medical care due to cost. Wheelchairs, walkers, cochlear implants, etc. These things are all very expensive. And as soon as you say they're for people with disabilities, the price of those things usually goes up. And for people with disabilities, they usually need about 28% more income to have the same income as, or same quality of life as people without disabilities. One of the questions I get asked a lot from people is, how should I refer to people with disabilities? I don't want to offend somebody and say the wrong thing. So what's the best way to refer to people with disabilities? I would say always use person first language. So a person with a disability rather than a disabled person. But there are, of course, exceptions to that. You meet one person with a disability, you've met one person with a disability. So some people prefer identity first language. That's particularly true of deaf people. They don't necessarily relate to the disability community. They feel like they have more of a communication and language barrier. So they're usually refer to themselves as deaf with a capital D. Blind people, many of them also feel the same way. It's blind with a capital B. One thing I would say also for those of us who use wheelchairs, please don't use the term wheelchair bound. You see that a lot in news articles and things like that. But wheelchair bound is kind of like nails on a chalkboard to people who use them. It's wheelchair user. People with wheelchairs see their wheelchair as something that provides them with freedom, not binding them. And using that as a very negative kind of term for people. And instead of using people, so referring to people who don't have disabilities as normal, instead refer to them as non-disabled. And using terms like differently abled or, physically challenged, etc., are often considered more condescending. And, those of us who are disabled, we know we're disabled, so that's not something that we're ashamed of, and using various other terms just makes it seem like people are embarrassed or ashamed about it. And then it's really important also, I think, to keep in mind that not every disability is visible. People can be disabled and not visibly use any device or service dog, etc. So it's not clear that they have a disability. So that's something to keep in mind. So you can type things into the chat if you'd like to play along, so to speak. Just curious what people believe the challenges are for accessing healthcare for people with disabilities. And you'll see me use PWD a few times just because it takes up less room on my slides. So if you feel like typing something in, you're certainly welcome to. Yes, absolutely. Access to specialists is difficult. Transportation is a huge problem. If we have anything else, I'm going to try and move ahead here. So physical equipment, exam tables, tiny exam rooms, not being able to get in the front door of buildings, no ramps, communication barriers, yeah, like no ASL interpreters or no interpreters at all. Large print material. I had some students who were doing the rotation in an eye clinic, and they said there was no large print material in the clinic. And I was like, yeah, well, that's something that you should bring up to them. Transportation problems and trying to get access. A lot of places will have like transportation, but it costs quite a bit of money. And then procedural barriers, and I'll talk about that in more detail in a minute. And negative provider attitudes. We saw during the COVID epidemic that people with disabilities were more likely to be denied access to ventilators because of the quality of life issues, that healthcare providers believe that people with disabilities do not have a good quality of life, even though most people with disabilities report they have a good quality of life. Providing inferior treatment, such as not getting exams because they can't get somebody onto an exam table, not being able to refer them for studies, etc. And not talking about general or preventative care like birth control or tobacco use or weight loss, etc. That's really a big problem and can run into a lot of health issues if these topics are not discussed with patients. And something I've seen quite a bit is patients don't trust providers because they've had such negative experiences that they do not go to see healthcare providers, and as a result end up with really bad outcomes. I have some friends who've waited till really last minute kind of thing, yeah, medical PTSD, and have had very life-threatening issues occurred and ended up in the emergency room. So what can you do to help make this situation better? Well, one thing that's pretty easy, and there's a link to this, there's a checklist to go through your practice and see where you find issues. So where is there like a trash can in front of the elevator buttons? That's one that drives me crazy all the time. Or a plant, or how about any kind of weighing scale for people with disabilities, or a high-low exam table. So you can just go through this checklist and see how well your physical facility is accessible. One thing I've never seen, but I think would be really nice and go a long way for helping people feel welcome and included in your practice, is to advertise a commitment to accessible healthcare. So just having a sign saying, you know, we are trying to make care better for our patients with disabilities. Please provide comments, you know, either at the front desk or your Press Ganey survey or whatever, as to what we could do better. Doesn't mean that you've said, okay, by tomorrow I will have all this accessible equipment, but at least you will know what the pain points are for your patients. Update your policies and procedures to make sure that they do take into account patients with disabilities, and having a communication plan and emphasizing, as I said before, health promotion. So the communication plan, do you have interpreters? Do you have a list with phone numbers? Do you have large print, etc.? And in terms of the policies and procedures, this is rarely done. I always have to say this, but I think this should be something on checklists that providers have, where they say, I want to, you know, I need to have a Hoyer lift, or I need to have an interpreter, etc., and put that in their notes for their medical record. So it's not a surprise when somebody shows up for their appointment and they're like, oh, I didn't know you needed this, which has happened to me a million times. Reserve your equipment and make sure staff is available for help with that. Sometimes I've gone to appointments that happen over lunch and everybody's gone, so they can't get me into a lift. Training your staff in safe transfer techniques. If you have an OT department in the hospital, you can ask them to do an in-service on transfers or PT. How to interact with people with disabilities. There's a number of different videos. I've got some on the resource slide. And then, as I said, having forms in large print, having a list of ASL interpreters available so you know who to call, and you cannot charge patients for interpreter services. And then having it be available to email or text if you want to communicate, or appointments. I think in terms of people being able to use those patient portals, that's helped quite a bit in that regard. I want to make people aware that the Department of Health and Human Services came out with a rule in 2024 that said by 2026, weight scales and exam tables, at least one in your practice has to be accessible. Now, if this will cause an undue burden, they can opt out of it, but you would have to prove that that was an undue burden and something that you couldn't do. I would like to say that the Health and Human Services Department will honor this, but given the way some of our things have come out under our current administration, this may or may not continue to be the case. But currently, this is the deal. And while this particular article or study was done in 2012 with over 2,000 practices, primary care practices in California. These graphs are really still pretty true, that there are very few height adjustable exam tables and even fewer accessible weight scales. And if they do have a weight scale, they put it in a corner where it's difficult for somebody to actually get their wheelchair up and onto it. And I mean, being weighed is a very important thing for, you know, if you're getting a drug infusion, or you want it for preventative health care to see, is this person gaining weight? Are they losing weight? Maybe they might have cancer and suddenly they've lost a lot of weight. Well, if you can't track that, other than just the patient saying, yeah, I feel like I've lost weight, that makes it difficult to keep an eye on that. Some of you may have seen these accessible tables but they will raise and lower. And as you can tell from this picture of the individual in a wheelchair in the middle, those fixed or box type uh, exam tables are impossible to get onto. Now, it's not just for people in wheelchairs. I mean, people who are short, people who are like elderly and have a difficult time hopping up to these tables. Having something that adjusts makes it a lot easier for people. And they raise up, so it's not that the providers are going to get, back pain or whatever from leaning over. You can move that up to a place you can get to. And there were tax deductions available for scales and exam tables. You could take that off on taxes. I'm assuming that is still the case and will stay the case, so fingers crossed. But also making sure that your MAs, nurses, etc., know how to use transfer boards, gait belts, portable lifts. So the Hoyer lift over on the right with the patient in that. I've had MAs say, oh, well, I just watched a video like 5 minutes ago, so I know how to use this. It's like, okay, that doesn't instill a lot of confidence in me. So making sure that people know how to use this ahead of time is really important. So really important that you avoid making assumptions about people, about their limited cognition, whether they are sexually active, what their quality of life is like. Talk to them, not their caregivers. Do take a sexual history. I know a number of people have run into problems because no one asks those questions. And if you do that question where you feel safe in your home, is the caregiver present? Because maybe they're the ones not making that person feel safe. And sorry, I've got the chat covering my presentation here. And make eye contact, because if the caregiver is present and you ask them, did they feel safe? If you're not looking at them, you may miss some key signals. But ask, what's the best way to transfer you, communicate with you, guide you, and respect what they say and how it's going to work best for them. I see that I'm getting kind of low on time, so I'm not going to go into this in a whole lot of detail, but here's some various tips for working with deaf and hard of hearing people. Making sure that you don't cover your mouth. Not everyone can use ASL or needs to. They may have hearing aids, so it just minimizing any background noise will help quite a bit. And it's so important for people who are visually impaired that you identify yourself, explain what you're doing before you approach them or touch them to do any kind of procedures. I brought up this point because I have had people in clinics ask me, how do I deal with service animals and emotional support animals? Emotional support animals only have access to housing. They do not have public access, and people don't understand that difference. So service animals, you can only ask 2 questions as to whether the service animal is required because of a disability or what work or task the dog has been trained to perform. So if they say, oh, well, Fluffy is here to comfort me when I'm anxious, that is not a service dog, that's an emotional support dog. And you're welcome to weigh in on who you think in these pictures is a service dog. I will tell you, service dogs do not have to wear a vest. And some people just buy a vest on Amazon and call their dog a service dog. So you may be asked as healthcare providers to provide documentation of whether this person needs a support animal, and it's going to be on you to make sure that's really what they need. Getting down here to the last few slides. So don't worry if what you say to somebody is difficult for them to do. Work with them and see, how can we make this work? How would this be feasible for you? and really think about how that's going to help them and partner with your patient to come up with ideas. And I know for some people it can be, you can feel anxious about working with people with disabilities. You may have not had experience with them, and you just, feel uncomfortable. Just looking at this as being open to diversity in any other form, respecting individuals and seeking to understand them and what their unique needs may be. So here's a list of resources that are available. This one down at the bottom is not really, doesn't particularly explain things to you, but it was a really great YouTube video by some people with Down syndrome that I thought was a really great video. So I would recommend just having a look at that. It's pretty short. But these are some good resources that I've found, and you're welcome to look at those. And that's it for me. Let me go. I know I went over by a minute, so apologies for that.
Thank you, Ingrid. Anyone who's here, if you still have any questions, go ahead, put them in the comments or unmute yourself. I know I learned a lot from that presentation, so excited about that. And on this screen, it lists our next one, our next scholarly snippets. I will put the link for that and for our survey in the chat. If you get a chance to do either of those. So I don't see any questions left. So I guess we will wrap it up. Again, thank you, Ingrid, for that presentation. I for one, really learned something and appreciate it. So
you are so welcome, and thank you for the invitation to present to everybody.